So most of the stuff is pretty straightforward. Most of you probably won't even watch this because I think you learn a lot of this when you're in your gym med rotation. But I'm going to focus on some of the highlights, and I won't pontificate on stuff that you already know or likely know. So, uh, what happens when we go into renal failure? Initially, most people don't have a lot of symptoms until the GFR gets really low, as in less than 30 or even less than 15. But the first symptom that you might notice would be like volume overload, somebody who's got increased peripheral edema. And the preferred agent to manage peripheral edema in somebody with kidney injury or failure is going to be furosemide or bumetanide, so loop diuretics. And we give loop diuretics over hydrochlorothiazide for patients with volume overload because they have less of a chance of causing hyponatremia. Okay. And then, again, as the kidney fails, you can't recycle your bicarbonate, causes a lower pH, loss of EPO with anemia, and and the key to that would also be that they have a low reticulocyte count. So that's something to bear in mind. If you think somebody has an anemia from their kidney disease, low reticulocyte count would help you diagnose that. And then lots of electrolyte abnormalities. And again, these usually don't start occurring until they're pretty far along with their reduced GFR. Uremia. This is when we get down to really low GFR and the buildup of nitrogen waste products that we can't excrete. And these are going to be the causes, uremia, of the different complications that require us to go in and start emergency dialysis. And then please be aware that chronic kidney disease is a major risk factor for heart disease. These patients have a greater chance of dying from CV disease than they do from actually even starting dialysis. So that's something to be very strongly aware of. All right, and know your indications for dialysis. Pericarditis, and maybe they give you the classic pericarditis vignette, and they try and bait you into saying, okay, let's just give them NSAIDs, which is what you should do normally. But in the case of uremic pericarditis with a creatinine of 30 or whatever, we should probably go ahead and do dialysis. So again, you have a patient who's bleeding from the nose or a GI bleed, and they tell you they cauterized or done this or that, and it's still bleeding, and they have an increased creatinine and low GFR. Then that's a case where maybe they're just bleeding because they have dysfunctional platelets, and that's an indication for dialysis too. And I don't know how they test you on fluid overload. And then obviously potassium that is refractory to medical management is a big reason to have emergency dialysis. Oh, and metabolic encephalopathy. And I just want to point out that uremia from kidney disease presents very similarly to that of, hepatic encephalopathy. Both cases usually cause the asterixis or the hand flapping. And I think when you're looking at diagnosis on the exam, somebody who has an increased blood urea, nitrogen level, and evidence of altered mental status, confusion, they need dialysis is what you should be thinking. All right, and just some pearls here about chronic kidney disease. Let's see, what should we really focus on here? I don't want to go through all this with you, but I think ACE inhibitors. All right, so anytime on your shelf somebody has kidney disease or even diabetes, you should start them on an ACE inhibitor. That's always the answer. It is proven to help these people. It stops hyperfiltration. That's great, but it's always the answer. So diabetes, kidney disease, or kidney disease in general, even if it's not diabetes, always choose an ACE inhibitor if you're trying to control the blood pressure. And for anybody who has any kind of kidney disease, we want to keep the blood pressure, below 130 or 140, because that helps prevent deterioration, hyperfiltration, and ultimately proteinuria and failure. Okay. So strict hypertension management is key. Again, loop diuretics are better than HCTZ, and that's pretty good. Oh, and this is important. So, all right, this is not in UWorld, so write this down or something, okay? Everybody with diabetes should do these three things: stop smoking, start a statin drug, and use a low-protein diet. Know those three things. This is the kind of thing that shows up on the test. Okay, and let's do AKI. And there's three types. You all remember them. And pre-renal mostly being things that cause hypovolemia, like losing fluid volume, or importantly that you remember that CHF and cirrhosis can cause a pre-renal injury, and they can still look swollen to you, and they can still have 2-3+ pitting edema, but be intravascularly dry with low effective arterial volume. So keep that in mind. And then intrinsic renal disease, or ATN, the classic thing here should be muddy brown casts, and we should not have muddy brown casts with a pre-renal injury. In fact, pre-renal injuries should only have bland urinary findings, maybe hyaline casts. They should not have any white blood cell, muddy brown, any kind of abnormal casts. The exception to that would be somebody who had a pre-renal injury, and after several days, for whatever reason, the ischemic process was bad enough to cause necrosis. They're going to sustain an ATN and have muddy brown casts. All right, and the causes of ATN, we'll go through them in a minute. And just be aware from a post-renal standpoint that multiple sclerosis, by way of causing an emergent bladder with retention, or BPH, also doing that same thing. Urinary retention builds up in the ureter, compresses the kidney, hydronephrosis. That's a post-renal injury. So differentiating AKI, pre-renal versus intrinsic renal, I think is really important for you to know. The key thing here is you think somebody's volume down, give them IV fluids, and if the creatinine comes back to normal in 2 or 3 days, bingo, it's pre-renal, we're done. So lab findings they might give you would be if their urine sodium is less than 25, and usually it's going to be less than 20 or even lower, and their FV sodium, or fractional excretion of sodium, is less than 1%. Both of those together very strongly suggest pre-renal disease. Now, the one exception is if they have chronic kidney disease. And if they have chronic kidney disease, then it doesn't matter if they're pre-renal. They can't recycle the sodium, so they're still going to lose excess amounts of sodium in their urine, and they'll have a picture of ATN with 2% or greater FeNA and sodium greater than 40. That's if they have CKD, okay? So in that case, instead of using the fractional excretion of sodium, you could use a fractional excretion of urea, okay? So keep that in mind. So volume repletion is the way we treat pre-renal disease, except when it's congestive heart failure or cirrhosis. Now, the classic reason that this happens is that these patients have surgery, or they're on too much diuresis, and it causes them to have, essentially not enough blood volume, and they still have their pitting edema. So the treatment for this is you do not give them fluids. What you do is hold diuresis, okay? And if you hold their diuresis, usually their kidney function improves in a day or two. All right. So with acute tubular necrosis, ischemia or a pre-renal cause could cause that again if it's prolonged and bad enough. And the evidence of that would be muddy brown casts. And the other things we'll see here are, like we talked about, increased sodium loss and 2% or greater on the FeNA. You know that, you're going to be good. And I think that's all you need to know. Here's a picture of muddy brown casts for you, just so you remember that. And hopefully that's not on your test, but you never know. So real quick, the different things that cause acute tubular necrosis, aminoglycoside antibiotics. Big thing with this is if they're on therapy for more than 5 days, it's almost a guarantee this is going to happen. If they're older, and the way we can prevent this is by trying to limit or reduce the peak serum concentration, and that's by measuring that you can help prevent this. And dosing these medicines only once per day is a good way to stop this versus twice daily, of course. So with rhabdomyolysis, lysis, whatever, breakdown of muscle, the problem here is myoglobin. The kidney doesn't like myoglobin. It kind of gets stuck in there and essentially just causes an acute kidney injury. And same thing with contrast nephropathy. 2 to 3 days after contrast imaging, the two things are pretty easy to separate when you see them in the history, but what I wanted to point out to you is that heavy hydration is the way we treat both conditions. We prevent both conditions with hydration, and we treat them with hydration. That also goes for somebody with a crystal-induced nephropathy if they were on a protease inhibitor or a cyclovir and developed an obstruction with an increased creatinine. Same thing, heavy hydration is the way to prevent and treat those complications. The diuretic overuse is something that you may see, and the key to noticing that is somebody who has CHF or cirrhosis and their urine analysis shows increased electrolyte levels when maybe they shouldn't have. Like pre-renal disease, like we said, should have low sodium and and really low potassium as well. If you see increased levels of those different electrolytes, it suggests that there's a diuretic overuse problem. All right. And then interstitial nephritis, this is all over UWorld, so I'm not going to hammer down on it, but someone who had a drug reaction, started a new drug, and they've got a rash, and they've got eosinophils in their peripheral blood, and they've also got these urine symptoms like decreased urine output or bloody urine. And then the key thing that you'll always get this question with is white blood cell casts. It's the only thing that causes white blood cell casts. You see that, we're done. Peripheral eosinophils and eosinophils in the urine is also super specific for this disease. How do we treat it? You stop the medicine that caused it, and that's it. Know the definition of analgesic nephropathy. It is essentially the same thing as interstitial nephritis. It's just a less acute presentation. So somebody who comes in with a little blood in their urine and they've been on NSAIDs for 20 years, they have analgesic nephropathy, and it's due to papillary necrosis.